In this presentation, we will discuss the assessment, management and prescribing principles of infection in postnatal women. When prescribing, we need to consider the risk-benefit balance in the postnatal period, as many medications are not licensed in breastfeeding women. In addition, the cohort of women who are having babies are on average older than in the past, which means an increasing number of women will have multiple comorbidities, which need to be taken account of when prescribing medication. Why is it important to follow local microbiology guidance? It is important for several reasons, all of which contribute to the effective treatment of infections and the control of antibiotic resistance. First, local microbiology guidelines are based on the most common bacterial pathogens and their resistance patterns in a specific geographic area or healthcare setting. These guidelines ensure that antibiotics are chosen based on organisms that are circulating locally, maximising the chance of effective treatment. Second, local guidelines minimise antimicrobial resistance, where the misuse or overuse of antibiotics can lead to the development of antimicrobial resistance, and therefore slow the emergence of resistant strains in the area. Third, this improves patient outcomes as antibiotics are prescribed that are more likely to be effective against local bacterial strains, leading to faster recovery and reducing the likelihood of treatment failure. Fourth, optimization of antibiotic stewardship, which aims to optimize antibiotic use to ensure efficacy while minimizing side effects and resistance. Finally, the overuse of broad-spectrum antibiotics can kill a range of bacteria, which can lead to superinfections such as C. diff. Essentially, following local microbiology guidelines ensures the right antibiotics are used in the right context to safeguard both individuals and public health by combating the rise of resistant infections. There is an excellent free healthcare app called MicroGuide, which can be downloaded to your smartphones. Here you can select your individual trust's access to gain access to local prescribing guidelines. An example of the MicroGuide is shown on the slide there. Before prescribing antimicrobials for pregnant women, you should also consider the following. Is there clear evidence of infection? Has the patient received previous antimicrobial treatment? What is the allergy status of the woman? Is she taking any concurrent medication? Does she have any concurrent comorbidities? Is she breastfeeding? I will go into breastfeeding a bit later on in the presentation, but we must remember that the excretion of most drugs in breast milk is low, but that possibility needs to be discussed with mothers. Latest evidence and guidance can be checked on useful databases called LactMed and also on the UK Drugs in Lactation Advisory Service. After prescribing, remember to review all antimicrobials within 72 hours of initiation. Stop if there is no further evidence of infection. Change antibiotics by either de-escalating or escalating as appropriate, or continue and justify this in the notes. Should we prescribe antibiotics for everyone? The simple answer is no. Antibiotics should not be prescribed to everyone, as inappropriate antibiotic use can have serious individual and public health consequences. The overuse or misuse of antibiotics contributes to the development of antimicrobial resistance. Bacteria can evolve mechanisms to survive antibiotic treatment, rendering those drugs ineffective. As more bacteria become resistant, treating infections becomes harder, potentially leading to untreatable superbugs. Antimicrobial resistance is recognised as one of the greatest threats to global health. Resistant infections lead to longer illnesses, more complicated treatments, and increased mortality rates. Antibiotics are ineffective against viruses. Many common illnesses, such as colds, the flu, bronchitis, are caused by viruses, which are unaffected by antibiotics. Prescribing antibiotics for viral infections has no clinical benefit and can cause harm by promoting resistance and side effects. During viral outbreaks, such as COVID-19, overuse of antibiotics in non-bacterial infections can lead to unnecessary side effects and make bacterial infections harder to treat. All medications, including antibiotics, can cause side effects. Common side effects of antibiotics include diarrhea, nausea, allergic reactions, and in severe cases, life-threatening conditions such as anaphylaxis or C. diff infections. Antibiotics can wipe out beneficial bacteria that help keep harmful microbes in check, allowing pathogens such as C. difficile to grow unchecked, leading to serious secondary infections or superinfections. When antibiotics are overprescribed or misused, resistant bacteria can spread throughout the community, making future infections harder to treat for everyone, not just the person who received the antibiotic. And lastly, prescribing antibiotics unnecessarily may mask symptoms or delay the identification of the actual cause of an illness, particularly if the infection is viral or non-infectious. Patients believe they are being treated effectively when they are not, leading to prolonged illnesses or complications. In summary, antibiotics should be used judiciously and only when absolutely necessary to treat bacterial infections. Overprescribing harms both the individual and society by promoting resistance, increasing health risks, and reducing the effectiveness of these vital medications. When prescribing antibiotics in postnatal patients, it's essential to consider several factors to ensure both the safety of the mother and the baby, especially if the mother is breastfeeding. The postnatal period can involve specific infections or complications, so careful selection of antibiotics is crucial. The questions asked should provide information on factors that are critical to the risk assessment for each patient. Adverse outcomes can often be avoided by the appropriate therapy informed by a good risk versus benefit assessment. So what information should you gather? Information about the patient should include their age, general pre-existing health conditions such as diabetes, renal impairment, a history of allergies, especially to antibiotics, should be factored into the choice of treatment. Diabetic patients, for instance, may be more prone to infections and might require more aggressive management. Always check the patient's allergy status, particularly to common antibiotics like penicillins or cephalosporins, to avoid allergic reactions. Is the patient breastfeeding? Breastfeeding considerations include antibiotic excretion in the breast milk. Many antibiotics are excreted in breast milk in varying amounts. The choice of antibiotics should prioritise those that are considered safe for breastfeeding, and the potential effects on the nursing baby should be minimal. Antibiotics that are safe to use during lactation include penicillins, cephalosporins, and macrolides, for example, erythromycin. However, some antibiotics, such as tetracyclines, quinolones, and sulfonamides, may pose risk to the baby and should be avoided unless absolutely necessary. It's important to monitor the infant, even when using antibiotics considered safe for breastfeeding, by monitoring for side effects such as diarrhea, rashes, or yeast infections. It's important to consider if there is any surgical history, such as a caesarean section. Patients who have undergone a caesarean section may be more prone to certain infections, such as surgical site infections, compared to those who had vaginal deliveries. Wound infections in C-section patients often require antibiotics that cover skin flora, including staphylococci. In addition, antibiotic therapy may need to be combined with proper wound care for surgical incisions or episiotomy sites. It's important to note if the patient has previously received any antibiotics. This is in relation to antibiotic resistance. Postnatal patients, especially those with hospital-acquired infections or who have had prolonged hospital stays, may be at risk of infections with resistant bacteria. Therefore, choosing antibiotics based on local antibiograms and resistance data is crucial. We should also consider the patient's recent antibiotic use, as this can influence the selection of empiric therapy to reduce the risk of promoting further resistance. And always ask yourself, is there any evidence of infection? What is the type of infection? Common postnatal infections include wound infections, urinary tract infections, endometritis, which is infection of the uterine lining, mastitis, which is breast tissue infection, and perineal infections after vaginal delivery. Antibiotics should be selected based on the likely causative bacteria for the infection, for example, gram-positive organisms in mastitis and anaerobes in endometritis. Empiric therapy should cover these likely pathogens until culture results guide treatment adjustments. Always perform a physical examination, as this will give you important clues as to the nature of the infection. Review recent investigations. Have there been any investigations? What are the results of the blood tests, imaging, blood cultures, or microscopy and culture results? After you've gathered all the information, you should try to formulate a diagnosis, and then use information resources such as microguide to help prescribe antibiotics, taking account of resistance, dosing adjustments, oral versus intravenous, side effects, risk of superinfections, and duration of treatment. The postnatal period may involve changes in body fluid volumes, renal function, and metabolism, potentially altering drug pharmacokinetics. Dosing adjustments may therefore be required, particularly in cases of renal impairment or weight changes after delivery. Depending on the severity of the infection and the patient's clinical status, oral or intravenous antibiotics may be required. Severe infections like postpartum endometritis or septicemia may need IV antibiotics initially. Always consider the antibiotic side effects and the impact on maternal recovery. Consider these side effects, especially those that could complicate postnatal recovery, such as gastrointestinal disturbances such as diarrhea and nausea, yeast infections, and allergic reactions all impede recovery. Think about the risk of superinfections. Broad-spectrum antibiotics can increase the risk of superinfections such as C. diff, and choosing narrow-spectrum antibiotics where appropriate can help reduce this risk. What is the duration of treatment? Again, avoid prolonged use of antibiotics. The duration of antibiotics should be carefully considered to avoid unnecessarily prolonged use, which can increase the risk of side effects and resistance. Follow evidence-based guidelines for the appropriate duration depending on the type of infection. And lastly, any antibiotic prescribing should be done in conjunction with your patient. There should be shared decision-making. It's important to discuss with the patient why antibiotics are necessary, the potential risk to the baby if the patient is breastfeeding, and the importance of completing the full course of antibiotics to prevent resistance or recurrence of infection. Ensure the patient is able to access the prescribed antibiotics and that the dosing schedule is practical for her, especially when caring for a newborn. In summary, prescribing antibiotics for postnatal patients requires careful consideration of the type of infection, breastfeeding considerations, maternal health, and local resistance patterns. The goal is to provide effective treatment while minimising harm to both the mother and the baby. Breastfeeding considerations when prescribing. The choice of antibiotic to treat any condition depends primarily on the organism likely to be causing the symptoms, as well as taking into account any previous allergies, for example a rash in response to penicillin. Most antibiotics, as mentioned before, can produce excessively loose motions in the baby with the appearance of diarrhea. Some babies appear more unsettled with tummy aches or colic. These effects are not clinically significant and they don't require any treatment. Furthermore, the value of continued breastfeeding outweighs the temporary symptoms. Some antibiotics, for example gentamicin and meropenem, are given intravenously as they are poorly absorbed from the gut. Any drug passing into breast milk is therefore unlikely to be absorbed in sufficient quantities by the baby, and there is no need to cease breastfeeding on safety grounds. In the past, it was believed that tetracycline antibiotics were contraindicated in breastfeeding because they could stain the infant's teeth, even if they had not appeared yet. However, in short courses, which are less than a month, this appears not to be a problem, as the drug forms a complex with the calcium in the milk and is not absorbed by the baby. However, long courses, for example for use in acne, should be avoided wherever possible. Metronidazole has been said to impart an unpleasant taste to the milk and can cause the baby to reject it. Babies don't seem to be concerned by the frequent variation in the taste of breast milk which occurs naturally. Further advice on specific medication prescribing in women who are breastfeeding can be found on the LactMed website. I wanted to include a slide in my presentation about prescribing in women who have a penicillin allergy and what are the important things to consider in this group of women. Now, allergies to antimicrobials are most likely with penicillins and cephalosporins. Anaphylaxis to medication begins and progresses really rapidly. The most common sign is severe persistent hypertension, normally with tachycardia. There is also flushing, urticaria, angioedema, pruritus, and respiratory symptoms, which may or may not be present in the patient. It's therefore really important to check allergy history immediately before prescribing any antimicrobial. It's important to understand which antimicrobials are contraindicated in which allergy. For example, which products are penicillin-based. Cephalosporins are a class of antibiotics closely related to penicillin. There are a number of cephalosporin medications available, and you've probably heard of quite a few of them, including cefalexin, cefaclor, cefuroxim, cefadroxil, to name a few. People with a history of penicillin allergy have a small risk of having an allergic reaction to cephalosporins. If possible, penicillin skin testing should be performed in these individuals. Since testing will be negative in about 90% of these people, a negative test will allow them to take cephalosporins safely. However, if there is a positive skin test to penicillin, there is a higher risk of an allergic reaction, particularly to some cephalosporins that share an additional part of the chemical structure with specific penicillins, and these require more caution in terms of how the cephalosporin is administered. Penicillin allergy is commonly reported by patients in about 10 to 20% of patients. We should be cautious before we apply the label of penicillin allergy to any patient. A true penicillin allergy can provoke a number of severe and potentially fatal immune-mediated events in a small number of patients who are predisposed. Avoidance of penicillin indefinitely is critically important in such patients. Presentations are variable and include anaphylaxis, urticaria, and angioedema occurring immediately following exposure, and severe cutaneous reactions such as acute generalized erythematous pustulosis, or AGEP, Stevens-Johnson syndrome, toxic epidermal necrolysis, and DRES, which is a drug rash. Patients who have previously tolerated penicillin can and do react, sometimes manifesting serious and fatal reactions. It's important to remember that prior tolerance does not exclude the risk of allergic reaction to penicillin. Non-immune mediated effects of penicillin, such as minor gastrointestinal upset caused by alteration of gut flora, salt and water retention in patients with renal impairment, and cerebral irritation at very high doses, can lead to an incorrect penicillin allergy labelling. On the right is a table of possible reactions that can take place with penicillin and guidance as to whether these should be prescribed in these groups of patients. In the next few slides, we will go through specific scenarios and considerations for prescribing. I would like to start with instrumental delivery first. Many women who have an assisted vaginal birth, either with a forceps or a vacuum cup, develop infections. In fact, over 1 in 10 women with assisted vaginal births develop an infection. So who needs antibiotics after an assisted vaginal birth? The ANODE study, which was published in 2019, showed that preventative antibiotics, i.e. given before infection develops, reduces the risk of infections following an assisted vaginal birth. As a result, guidelines on the use of preventative antibiotics were updated in 2021. They now recommend antibiotics after all assisted vaginal births. The ANODE study included women who received preventative antibiotics, amoxicillin and clavulanic acid, or a dummy drug or placebo, up to 6 hours after an assisted vaginal birth. They found that preventative antibiotics reduced infections compared with placebo among women with assisted vaginal births, whether they had a surgical cut, a tear, or both. The risk of infection was decreased by a delay in giving antibiotics. Women who waited more than 6 hours after giving birth were twice as likely to develop an infection compared to those who received antibiotics within 15 minutes. In fact, every additional 15-minute delay increased the risk of infection by 3%. The risk of infection was also increased by episiotomy, where infection was almost 3 times more likely than after a perineal tear. The risk of infection was also increased by the use of forceps and if it was the woman's first birth. The analysis also provided some evidence that women who were overweight are at increased risk of infection. An infection commonly seen in the postnatal period is mastitis. Mastitis is inflammation and the inflammation of the breast, and often the first sign is a tender, hot, swollen area of the breast. Clinical signs and symptoms which we should look for are colour changes to the skin of the breast, flu-like symptoms with or without a fever. These symptoms can start suddenly and they may worsen quickly. Inflammation may or may not involve bacterial infection. If there is infective mastitis, there is no improvement or a worsening of symptoms after a 24 to 48 hour period, and/or there is a fever. The most common organism is Staphylococcus aureus, which is also found as part of the normal skin flora. When considering differential diagnosis, we need to assess for symptoms for other systemic infections and take a detailed history from the patient. An examination, which includes general appearance of the mother, the nipples and the breasts, the patient's medical history and obstetric history. It's also important to take a breastfeeding pattern history since birth, which includes any missed feeds, top-ups, frequency of pumping. In addition, any pain or tissue damage to the nipples or pyrexia due to other infections. Antibiotic treatment is indicated for infective mastitis. Again, we must apply the principles of prescribing, which includes considering local antimicrobial sensitivities and resistance data, previous experience and antimicrobial treatment that women have received for current or previous infections, and the allergy status of a woman. A commonly prescribed regime as a first choice is flucloxacillin 500 mg to 1 gram every 6 hours for 5 to 10 days. The second line, or if there is a penicillin allergy, is clindamycin at a dose of 300 to 450 mg every 6 hours for 5 to 10 days. It's important to note that higher and more frequent 6-hourly doses of antibiotics are required to ensure adequate tissue penetration and duration of treatment in this particular group of women is 5 to 10 days. You must reassess after 5 days of treatment, as failures do occur and the patient might require referral to hospital if they're not responding to treatment. If the patient is improving but not fully recovered or resolved from the infection, then the treatment course should be extended. Patients should be encouraged to either breastfeed or express to ensure milk stasis doesn't occur, and cold compresses and analgesia should also be used. Postpartum endometritis refers to a postpartum infection of the decidua that can affect all layers of the uterus. It's a common cause of postpartum fever and uterine tenderness. Most infections are mild and will resolve with antibiotic therapy. However, in a minority of patients, the infection can extend into the peritoneal cavity, causing peritonitis, intra-abdominal abscess, or sepsis. Postpartum endometritis is typically a polymicrobial infection involving a mixture of 2 to 3 aerobes and anaerobes from the lower genital tract. The risk factors for endometritis are caesarean births. In addition to this, women who've had chorioamnionitis during labour, prolonged rupture of membranes, meconium, manual removal of placenta, diabetes, preterm or postterm birth, operative vaginal birth, obesity, and group B strep are also at increased risk. In most patients with postpartum endometritis, the key clinical findings are fever, uterine tenderness, tachycardia that parallels the rise in temperature, and midline lower abdominal pain. The uterus may be slightly soft, which can lead to excessive uterine bleeding. The time of onset of signs and symptoms depends on several factors, including whether intrauterine infection developed antepartum, intrapartum, or postpartum, and the bacteria which is causing the infection. For example, group A streptococcus infection should always be suspected in patients with an early onset postpartum infection and high fever. In terms of evaluating your patient, it's important to take a history and physical examination to determine the possible source of the signs and symptoms, a complete blood count and CRP, as well as a urine culture, and where appropriate, a vaginal swab. Postpartum endometritis is primarily a clinical diagnosis based on characteristic signs and symptoms, which includes a fever, pain or tenderness with no other recognised cause, purulent drainage from the uterus. Fever is a key sign because of the variable degrees of midline abdominal pain, uterine tenderness, and leukocytosis are quite common after caesarean section, and to a lesser extent after vaginal birth, even in the absence of infection. When considering a differential diagnosis in patients with postpartum fever but no or minimal uterine tenderness or purulent vaginal discharge, we should consider causes such as appendicitis, which can present with fever in the postpartum period. In addition, surgical site infection, if there's been an episiotomy or perineal laceration, mastitis or breast abscess, and pyelonephritis. Prompt administration of appropriate antibiotics is critical in septic patients. It's important to treat endometritis to prevent sequelae such as peritonitis, salpingitis, abscess, and septic pelvic thrombophlebitis. Broad-spectrum parenteral antibiotics that include coverage for beta-lactamase producing anaerobes are typically recommended given the microbiology of these infections. When evaluating perineal wounds, patients who present with extreme or worsening pain, particularly if associated with fever or general malaise, often indicates an infection. Perineal infections generally occur during the first week after delivery, but individuals can present with symptoms 2 to 3 weeks later. Infection can be limited to the laceration or expanded cellulitis, an abscess, or in extreme cases, necrotizing fasciitis. Infection or an abscess can track into the ischiorectal fossa and present as buttock pain. The obstetric laceration repair can be intact or disrupted by the infection. It's important to perform a physical examination. Findings suggestive of perineal infection include erythema of the surrounding skin, shiny or tense skin, drainage, visible disruption of prior repair, and edema. Any patient with a concern of perineal infection should undergo examination, especially if there's concern of rectal involvement, including evaluation for foreign bodies in the rectum or fistula. Once a perineal infection is identified, it's important to prescribe the appropriate antibiotics if there are signs of abscess or a soft tissue infection. If, however, there is an abscess, the repair needs to be opened and the abscess needs to be drained. A surgical site infection is an infection related to a surgical procedure that occurs near the surgical site within 30 days following surgery. A wound infection generally develops 4 to 7 days after a caesarean section. Wound infections can be early, which occur in the first 24 to 48 hours, and are usually due to group A or B beta hemolytic streptococcus and are characterized by high fever and cellulitis. Later infections are most likely due to Staphylococcus epidermidis. Necrotizing fasciitis is a rare but life-threatening complication, which occurs in 0.18% of caesarean births. The clinical features of surgical site infection include erythema and induration, localized swelling, warmth, wound breakdown, dehiscence, and pain at the incision site. On palpation of the wound, the area may demonstrate induration or tenderness. Some patients will have systemic evidence of their infection, for example, fever and leukocytosis. Purulent wound drainage or separation of the wound edges are usually indicative of an infection. If there is a wound opening, then a gram stain and culture for causative organisms should be obtained. In terms of prescribing, the need for antimicrobial therapy is determined by the extent of the infection, presence of systemic manifestations, and patient comorbidity such as chronic glucocorticoids and diabetes. Definitive antimicrobial treatment is guided by the clinical response of the patient and, when available, the results of wound culture and sensitivities. Urinary tract infections include cystitis, which is infection of the bladder or the lower urinary tract, and pyelonephritis, which is infection of the kidney or the upper urinary tract. E. coli is the most common cause of an acute complicated urinary tract infection. The symptoms of cystitis include dysuria, urinary frequency and urgency, suprapubic pain, and hematuria. Patients with an acute complicated UTI also have a fever or other features of systemic illness, which suggests that infection has extended beyond the bladder. Symptoms of pyelonephritis classically include fever, chills, flank pain, costovertebral angle tenderness, and nausea and vomiting. Patients with acute complicated UTI can also present with bacteremia, sepsis, multiple organ system dysfunction, shock, and acute renal failure. The diagnostic approach to urinary tract infection is to examine the patient to assess for other causes of illness and perform urine studies. For all patients with suspected UTIs, a urine is sent for urine analysis for microscopy and culture. Most patients with acute complicated UTI do not warrant imaging studies for diagnosis and management. Imaging is generally reserved for those patients who are severely ill, have persistent clinical symptoms despite 48 to 72 hours of appropriate antimicrobial therapy, or have a suspected urinary tract obstruction, such as declining renal function. In terms of management, empiric antimicrobial therapy should be initiated promptly, taking into account risk factors for drug resistance, including previous antimicrobial use and the results of recent urine cultures, with subsequent adjustment guided by antimicrobial susceptibility data. A few notes and guidance to prescribing. Always refer to local resistance patterns for empiric therapy. Amoxicillin is not suitable for empirical treatment due to high rates of resistance and should only be prescribed when the pathogen is confirmed to be sensitive to amoxicillin. Always review empirical treatment with results of MSU culture and susceptibility. Trimethoprim should not be prescribed for pregnant patients with established folate deficiency, low dietary folate intake, or women taking other folate antagonists. Group A streptococcus, which is also known as Streptococcus pyogenes, is an aerobic gram-positive coccus that causes a broad array of infections. It's commonly associated with pharyngitis or skin infection. Less commonly, it can cause bacteremia or pneumonia. Toxic shock syndrome occurs as a complication of invasive Group A strep in 1/5 to 1/3 of pregnancy-related cases. The clinical presentation is with fever in 90% of patients, abdominal pain and tenderness, vaginal discharge, which is often accompanied by hypotension, tachycardia, tachypnea, or leukocytosis. The site of infection can be the uterus, the vagina, surgical site infections, breast, urinary tract, respiratory tract, and sometimes there is no identifiable site. On examination, there is uterine tenderness or a wound infection. There may be vaginal or cervical purulent discharge or inflammation at the site of a laceration. Rarely, there may be cellulitis or a rash. Investigations reveal leukocytosis, hemolysis, hemoconcentration, and thrombocytopenia, as well as an elevated CRP. The blood cultures are positive in 50% of patients. In patients with streptococcal toxic shock syndrome, there may be evidence of end organ damage, such as elevated creatinine or aminotransferases. Antibiotics are the cornerstone of management and should be administered with urgency, which means before the blood culture results return. Empiric antibiotic therapy before definitive diagnosis is made with broad-spectrum treatment is important because these organisms can cause shock and necrotizing infection in the postpartum period. When prescribing antibiotics for sepsis in postnatal patients, it's crucial to act swiftly and follow specific principles to ensure the best possible outcomes for both the mother and the baby. Sepsis in the postnatal period is a life-threatening condition, and early and appropriate antibiotic therapy is critical. The key principles of antibiotic prescribing for sepsis are early recognition and prompt treatment. Antibiotics should be administered within the first hour of diagnosis of sepsis, often referred to as the golden hour. Early signs of sepsis in postnatal patients include fever, tachycardia, tachypnea, hypotension, altered mental status, and decreased urine output. Secondly, start broad-spectrum empiric therapy and then de-escalate. Common regimes often include a combination of drugs to cover gram-positive, gram-negative, and anaerobic organisms. Cover the likely pathogens in the postnatal period, such as Staphylococcus aureus, E. coli, and anaerobes, which cause intra-abdominal sepsis. Thirdly, tailor the antibiotics to the likely source of infection. Is it from the uterus? Is this endometritis? Is there a caesarean section wound infection or an episiotomy site? Could this be a urinary tract infection, mastitis, or a breast abscess? Consider local antibiotic resistance patterns. In severe sepsis, combination therapy is often recommended in order to cover all the possible pathogens. Remember to change the dose and adjust for physiological changes that take place in postnatal patients, and regularly assess for renal and liver function, especially if using nephrotoxic or hepatotoxic antibiotics such as aminoglycosides. Adjust doses accordingly if there is evidence of organ dysfunction, as sepsis can impair renal and hepatic function. And remember to consider prescribing in breastfeeding. My final slide in this presentation is just to remember to consider conditions that can mimic infection. So several conditions actually mimic infection and can present with fever, such as breast engorgement, aseptic mastitis, postpartum thyroiditis, drug-induced fever, deep vein thrombosis, which actually presents with fever, localized leg pain, swelling and warmth, which could be confused with pelvic infection or sepsis. Autoimmune disorders often flare in the postpartum period, such as lupus, which can cause symptoms that mimic infection. And lastly, hematoma, which causes pain, swelling, and sometimes a low-grade fever, which resembles a wound infection. In cases where infection is suspected but not confirmed, remember to carefully clinically evaluate and perform additional tests to differentiate between infection and these mimicking conditions. Thank you for your attention.